Thank you all for coming. I hope you guys had a good breakfast. We have a good turnout in spite of the current predicament we're all in, and we appreciate you all joining us today. Without further ado, I'd like to introduce our CEO, Dr. Habib Torfi.
Well, good morning, everyone. It's a beautiful Saturday morning in Newport Beach area. I wanted to take a few minutes and share some thoughts with you as far as what is happening with the company. We went through some, of course, needless to say, challenging times, but nevertheless, the company stayed on key. We landed on our feet. This was really mostly possible because of the team at Invitrix, both in California and also in Asia. We managed to really stay where we wanted to be. There has been a pivot in the company where we actually have started our process of becoming what I call a premier cell therapy company. By that, we have started several pre-IND meetings with the agency. We have an IRB for COVID in Puerto Rico that was possible by our partner, Dr. Jose Huerta, who is here in the audience. I think he's having breakfast on the patio. You know, some of us have better options, and he's exercising his option. Having said that, I think it's really amazing that the company has really shifted. We are no longer interested in the manufacturing and safety of the products is always paramount to us, but we are focusing, and you can talk to the rest of the team that is here. We are focusing on animal studies. We are focusing on do we use a small animal or a large animal studies. So really, the focus on the company has changed, again, to relaunch the company, but this time as a premier global cell therapy company. And I'm very honored to say that I think our physician supporters, distributors, and clients are here to see us through this process. I think you're going to see a lot of different changes in the company in the next few years. Of course, 2020, I saw somewhere that someone had, from a Yelp standpoint, had given 2020 half a star. So we are waiting for 2020 to go so we can start 2021 with a new sort of outlook on life. One of the things that are happening, and I really wanted to share with you, those of you who live in California, there is a Proposition 14 on the ballot, and we really would like for everyone to really support the cause. As you know, this is a repeat of the $3 billion that was allocated. And even though we were not directly involved in the proposition or the serum projects, but we were the benefactors of the proposition in a way that that money went to build institutions and laboratories in the state of California, and most of the staff, the scientific staff that you see at that work in Invitrix, they were educated by those funds and those monies. Again, I think the fact that California is a powerhouse global economy is because we have, as a state, has always invested in education. The ex-governor, Father Ed Brown, started the whole UC system. That has really given rise to really a lot of industry in California. So we really want you to support Proposition 14. Again, I'm not a politician, but I think, if anything, I think that's a money well spent than any other subject that I see. I think we should always pay for education. Now, I also, as I said, in some ways, I see what we are going through currently as what I would call, we just went through having an earthquake of 8 magnitude, sometimes in February, March. I think what we see, there are aftershocks. And these aftershocks are big. 6, perhaps as an analogy. And we're going to continue to have these aftershocks with this pandemic. And we need to really stay tight. We need to, both from our health and also from a business standpoint, I think one needs to be cognizant that this thing is going to linger. One of the things that was disastrous is, to use the earthquake analogy, I think in US, we shut down the pandemic offices. We thought, living in California, that you're not going to have an earthquake again. That was very short-sighted, and we are paying the price. I think I would register my disappointment with the agencies in US that they did not do their due diligence and say no to the powers to be. For FDA, for CDC, and among other agencies in US, that they did not have the backbone to really support the science. And without really getting more political about this, but I really thought that we need to sort of share our thoughts and opinion with you. Lastly, I am indebted to the Invitrix team, every one of you, during this time of crisis. You rolled up your sleeve, you stayed. Both the California team and our team in Asia, Taiwan, and Shanghai, indeed, they rolled up their sleeve, they stayed, and saw us through this terrible time. And they were terrible, and they were tough. And I do not know to this day why they would stay, why they would come to work and risk their life and really support us to stay intact as a team to move forward. Again, with that note, thank you all for coming in. I think in some aspect you are heroic in your effort for coming in this morning. I just finished talking to Dr. Gupta, and Dr. Gupta was telling me, Habib, this is probably the best thing that we did. We are showing our clients, we are showing our partners, even during these difficult times, we are going to be a reliable source for you, both from a product standpoint and from an educational forum. And I want to share with you that today that's what we want to do. We want to have a forum where we can exchange ideas and information. At this point, I'd like to introduce my very good friend, longtime friend, a physician scientist, and someone that I always look up to and seek his advice. And he's a professor of 3 different departments in UCI. His resume is extensive. He's driven. I don't know what drives him, but he is definitely driven. With that, I will introduce you my good friend, Dr. Ranjan Gupta.
So, good morning. Thank you for all coming out today. And one of the things, I'm going to start with a couple of stories and little anecdotes, and then before I get into the talk. But When you think about why we are all here, right? We all believe that in the belief that regenerative medicine offers an opportunity for our patients to get better, right? And this pandemic is also an opportunity. When other companies have closed shop, other places have not been able to deliver what they did, Invitrix has doubled down in their commitment to advancement, into science, into education, because that's where the future is. If you want lightning to strike, right? If you want to make that change, what's the most important thing to make sure when lightning strikes? You got to stand out in the rain, right? You got to stand out in the rain so that it can actually happen. And so our CEO is somebody who has always been committed to educating and to advancing our field. When I started at UC Irvine many years ago, he was kind enough to leave UCLA and come help us develop an NIH-funded lab. His expertise in tissue culture was what actually got us to where we needed to be for a number of years. He is someone that's in the grassroots that understands the science, and he knows that going to the lab every single day, whether an experiment works or doesn't work, actually is necessary to keep on advancing the field. And that's the commitment Invitrix has had. Whether it's the pandemic, whether it's whatever crisis, we have to keep on doing the work to make our field go forward. Sometimes they're incremental changes, and sometimes they're transformative changes. But it's only by engaging in doing that matters. So this year, I'm going to be giving. I'm going to start the morning. I'm the opening act, and so that you don't fall asleep, I'm going to actually talk a little bit about what I do as a surgeon. I am an orthopedic surgeon. Talk a little bit about what that is, what it means. Apply it to a little bit of tissue engineering, a little bit about arthritis, and hopefully, in the next 30 minutes or so, give you something that you can learn about. Okay. So as an orthopedic surgeon, I do joint replacement. And so I'm going to ask you, if you can tell on these patients, let's see the videos, make sure they work. That's not working. Well, that's not good. These are supposed to be moving videos, so give me 30 seconds. It's basically her arms moving up and down, the same thing, arms up and down. Which shoulder, all these are meant to say which shoulder was replaced. And the answer is, for all these patients, I replaced both their shoulders. And they have near the video, I'm just going to keep going for the interest of time. What is orthopedic surgery? And orthopedic surgery is the management of the musculoskeletal system. Okay? And it ranges into a variety of different categories: trauma, spine, foot and ankle, pediatrics, sports medicine, joint reconstruction, hand and shoulder and elbow. I do a combination of trauma, joint replacement, reconstruction. Within bone diseases, when you think about bone disease, there are 5 different types of bone diseases: inflammatory, hereditary, metabolic bone disease, injury, and neoplastic. Okay? And what is often interesting to see is that skin conditions actually lead to bone conditions. There may be some dermatologists in the audience. Anyone know what this skin condition is? Dr. Marco? Psoriasis. Absolutely. This is psoriasis, right? And psoriasis is a skin condition which leads to this profound bony destruction. And these are the things when you are treating different diseases, there is a component, it's a multifactorial physician component of where it's going to land. And as an orthopedic surgeon, I'm just a dumb technician. Smart guys like Dr. Marco are the ones that are going to actually manage it in front line. People like you who are going to be treating our patients with systemic conditions like this are to help prevent seeing someone like me for their surgery. Right? Now, the things where you're unavoidable, where you have to see me, is when you have an injury, right? Fracture, no fracture, or if it's a little bit more grotesque, when your hand's cut off. Okay, so I'm also a trauma surgeon, and so this is a patient of mine whose hand was cut off. Here's the hand, and then 24 hours later, this is what his hands went after we've replanted it. Right? Those are ones where there's no ambiguity that you have to have it. Now, in elective surgery, and I'm going to focus a little bit, most of my comments, on shoulder surgery before I migrate a little bit. So the shoulder is a part of the body. It's the upper extremity. It has 3 bones: the scapula, the humerus, and the clavicle. Now, the shoulder has one of the greatest range of motions possible, right? It allows for passive stabilization, active stabilizers, and this provides a stability to the joint so that you have the range of motion. The active stabilizers are the rotator cuff, the deltoid, the humorothoracic muscle, and scapulothoracic. The actual rotator cuff actually has 4 muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis. And it is in this area, when we do injections, when we do whatever sorts of treatments, we are trying to help improve healing, and I'll talk more about a little bit later, but it is at this tendon-bone interface in the shoulder, as well as deep down. When we look at the patients, when I see them, we get x-rays to look at what the joint looks like. Remember, x-rays are used to look at the bony architecture. You're not seeing the soft tissues. Those are just the shadows. And in this view, you can see, in this view here, you see this is the humerus, this is the scapula, and these allow us to look at the initial points of what the bones look like. And we always get multiple views to look at different types of things, whether it's a subacromial impingement, a chromial morphology. We get other views to look at to see what the bony architecture and whether the bones join. Now, what are the most common things that you see in shoulder surgery? Instability, rotator cuff fractures, adhesive capsulitis, and arthritis. And when we make our diagnosis, these are the major things, and some of it's based on age, acuity, physical therapy, and surgery. In these categories, okay, of diagnosis, when the surgery is, the word is maybe, well, that's when the opportunity for alternative medicine and other modalities are allowed, right? And the reality is there are almost all these conditions, there are alternatives to surgery. But as a surgeon, I don't want to go out of business, and I want to show you some of the values of what I do. So this is a 22-year-old. I'm going to show you some cases before I go to some science. So this is a 22-year-old male who injured his football while playing flag football. He was having difficulty with his overhead activities, and I think everyone can see this large bump. That's right here. Okay, and that's where his localized point tenderness, and he has what's called AC joint instability. And these are the pre-op imaging to show this area where the clavicle is no longer touching, because where the arrow is pointing here, these ligaments are torn, these ligaments are torn, and they're not going to grow back by themselves. So when you have a mechanical deformity, when you have a static change in bony architecture, that is a clear objective indication for an operation. Because those ligaments are not going to grow back, the bones are not going to move to where they need to be, and so we do the surgery. And the surgery is this, where we basically open up the shoulder, put the pieces back together again. This is the humeral head. I'm now sewing and recreating those ligaments. I use an allograft to reconstruct the AC ligaments, and then supplement it with an implant. And when you see now, look at this area here, it's restored the contour. There's a metal implant, there's ligaments, and that's what allows it to go back. In those situations, when you do an AC reconstruction, that is the case. Now, arthritis is one of the things that we all treat and have to be aware of. And I want to break it down and start moving. I'm slowly dipping my feet away from surgery to a little bit of medicine, and eventually I'll move into research in the animal models that we're going to talk about. But arthritis, when it affects a joint and of the shoulder, there are 2 main types, and they overlap. They're either primarily inflammatory or primarily non-inflammatory. And even if you have them, they will migrate one towards another. The inflammatory arthritis are the ones that have systemic disorders: skin rashes and ulcers, organ dysfunctions, cardiac, pulmonary, renal issues, hematologic disorders. The most common disorders are rheumatoid arthritis, SLE, psoriasis, and scleroderma. Rheumatoid arthritis is probably one of the most prototypic systemic disorder, and it has systemic autoimmune disorder, chronic systemic erosive synovitis, variety of different arenas. And this is one of the primary targets for biologics. This is one of the primary targets, almost all these systemic conditions. The field back in the Stone Ages, when I finished medical school, we just had started using methotrexate. Now the number of TNF-alpha blockers keep on increasing like gangbusters. And a variety, at some point we still haven't found the right answer, but we are moving in the right direction, so you eventually don't need to have that surgical intervention. And osteoarthritis is the most common joint disorder that leads to joint failure. It's multifactorial, genetic, and post-traumatic. What is the motivation? And this is from the CDC and from the NIH. When you look at the top 10 sources of disability, the number one thing is arthritis, right? And it involves and then the number two thing is back or spine problems, and those are also usually related to arthritis. Well, what is arthritis, right? And I'm going to come back to this, but I'm just now going a little farther into the pool, a little deeper end, starting using some of the science. Is that osteoarthritis is a progression. There are a progression of what a joint normally looks like to what it eventually wears out. I tell my patients who are not as not facile with the literature and understanding as all of you in the room, is it's like joints are like tires on a car. The tread eventually starts wearing out. And when that tread starts wearing out, there's a disease progression. The tread wearing out leads to proteoglycan loss, collagen damage. There are changes in the mechanical parameters of that articular cartilage. Decrease in elastic modulus, increasing hydraulic permeability, increased matrix deformation, and a decrease in load-bearing activity. Now this involves multiple joints. The most common joints are the hip and knees, then the shoulder, then the base of the thumb, and occasionally the elbow and fingers. When you look at what the joint, and this is a knee joint. When you look at the left side, and you now take histology slides. The right side is what a normal articular cartilage looks like, where there's bone, chondrocytes, and variety of different other tissue that helps form that articular cartilage. In the shoulder, this is a comparison. The new tire that you get from Firestone has that nice glistening white material. The right side, the osteoarthritic there's a cavitary defect. There are parts where that has worn away. And what does that happen? And I'm not going to talk about the biomechanical part right now. I'm just going to talk the gross morphologic part. Is that there's a progressive loss of articular cartilage. There's an attempt of repair of that. There's joint remodeling. There's sclerosis of the underlying bone. There are marginal osteophytes that are formed. There's cysts. And these signs, symptoms that lead to a variety of different joint destruction, restriction, motion, and this causes our patients pain. So what are our treatments? Well, the standard treatments. This is what we're taught: activity modification, analgesics, non-steroidals, appropriate weight loss. Well, the osteoarthritic component, experimental, and this is chondrocyte transplantation, hyaluronic acid joint injections, glucosamine, alternative medicine. These are arenas where people try to modulate and impact the disease progression. My goal in the rest of my talk is to tell you what we're going to be trying to modulate. There's a study that we did a while ago looking at the role of turmeric and curcumin, and we showed that actually turmeric actually decreases inflammation with tendon healing. And it's one of those things that tendon injuries often happen, and there's no gold standard for tendonitis. And so we actually looked at current treatments for tendon ruptures and showed that we ended up looking at how we could use alternative medicine. Well, curcumin is used for chemoprevention. People, the idea of things which is an Indian spice, people have been used for phase 1 trials for pancreatic cancer. And so why is it? It's because of its anti-inflammatory marker, right? For those of you who were here at last year's session, Dr. Kaplan talked about the role of mesenchymal stem cells and how important they were for modulating inflammation. A lot of things do that. So one of the studies we did was look at administering curcumin to help decrease inflammatory markers. And to help put that forward, we used an animal model. And this is a study we did in my lab where we created a small animal model. We transected transected the Achilles tendon, and then repaired them with a Kessler stitch. We provided both vehicle, low dose, high dose of the agent. And then we looked at inflammatory markers. We did mRNA upregulation of a variety of different inflammatory markers. We looked at TNF alpha expression. We looked at ILB expression. And what we ended up showing was that when you actually have any sort of injury, there's an inflammation that occurs. There's neutrophil recruitment, macrophage recruitment, and these, when you provide any pharmacological agent, in this case we curcumin, it modulates some of that remodeling, and it changes how the collagen is laid down. It changes whatever else. Almost all of what we are trying to do with alternative medicine and regenerative medicine is to modulate that response. This was an exploratory study with no expectation it would actually impact inflammatory markers. But we showed that curcumin significantly decreases mRNA and protein of inflammatory markers, TNF alpha and ILB. And one of the things why we look at this is that, and I want to introduce this topic to you, is that we at Invitrix are looking now to use small joint, just like when you look at an alternative medicine product, which is this, you have to show and publish that, okay, this actually does something and what we are doing with it. We at Invitrix are looking at small and large animal models to see what the products that you're delivering, what they're doing on a cellular and molecular level, and why they're important. So I'm going to keep going. I'm going to go back to a clinical case. This is a 47-year-old dentist with long-standing joint pain, failed non-steroidal Synvis injections, and had extremely limited joint range of motion. The imaging studies showed severe. These are the X-rays showed severe bone on bone. And what that means is when you look here, there's no joint space. There's bone right on bone. So now I'm going to show you some pictures of the surgery replacement. This is a skin incision I'm going to make. These are now deltopectoral approach, put in different retractors. Now you see the humeral head, and I'm gonna cut the bone, put in a prosthesis. Now start taking out tissue one by one, and then I'm going to when I now take out some of the issues I'm going to show you here. This is that once again that humeral head, which is not normal. It's speckled, and that humeral head is replaced with metal, and then here is your metal on plastic. Okay. So if we don't want to do that, and that's our eventual goal, the idea is there are current repair models and strategies to what happens to the cartilage. You can use osteochondral allografts or autografts. You can do autologous cell transplantation, or certainly the gold standard is microfracture, right, of what people are using in repair strategies. The current gold standard, is a total joint arthroplasty. And I've been showing you pictures of a shoulder joint replacement, but the most common ones are hips and knees. And there are multiple different ways to treat osteoarthritis, but this remains what we do, where we cut the ends of the bone off and replace them with metal and plastic. And the idea is, can we eventually make a biological joint replacement? Okay? And so in order to do this, you actually have to understand what that tissue does and how and what you need to recreate. Okay? It's not just putting cells where they need to be. It's not just even replacing tissue. Will that tissue be able to handle the functional loads and what aspect? And so this comes from the understanding that when those cells are in a certain tissue, they have distinct spatial and temporal, mechanical, electrochemical events that have to respond to. They end up having those responses are induced in biosynthetic activities. Now, what is cartilage, right? The cartilage, which is that soft tissue or the tire at the end of the car, well, it is composed. It has a distinct structure and composition. Okay, it is a type 2 collagen, which is 10 to 30% per weight. It has proteoglycans, it has water, and that's the largest component of the cartilage, is water. Proteoglycans and proteins, and the cells are chondrocytes. But the lion's share of what articular cartilage is water and type 2 collagen. That articular cartilage has multiple different zones. Okay, the zones are From that, there's a superficial zone, middle zone, deep zone, and each has distinct properties. Why are those properties so distinct? Because of the concept of mechanotransduction, which is how does a chondrocyte perceive its physical environment? Those proteins within the cells basically have mechanoreceptors, integrins, cytoskeleton, stretch receptors that stretch and respond to the external environment. In 1997, the field of tissue engineering took its leap, right? And the idea in this was that it's an Tony Atala at Wake Forest, who's a good friend of mine, basically helped launch the field with that. It's an interdisciplinary field that applies principles of engineering and life sciences toward the development of a biological substitute that restore, maintain, and improve the function of damaged tissues and organs. And that's where the field of regenerative medicine and tissue engineering and cell therapy started. Now, there are a lot of misconceptions, right? A lot of misconceptions are, this is way back when, where the idea of a bioengineered mouse with a human ears back, like, did we actually know what we were doing? Like, is there an idea from way back when? So before I go back into the cell, I tend to go back and forth to keep people awake, is that I go from the basic science to clinical medicine. So clinical medicine either makes you like jump up, or you're like, well, maybe it's something. But so going back to what we currently do, shoulder replacements have multiple different kinds. There's a hemiarthroplasty, total shoulder, and reverse shoulder arthroplasty. And what does that mean? There are the parts of the joint being replaced. It's the socket or the bone. And when I showed you these pictures, here's both ends of the joint are destroyed. And that's what the plain film x-rays are, to document that the foundation of that joint, the bony architecture, is abnormal. And so then we end up doing the surgery, which I just showed you previously, where you move the muscles out of the way without damaging the neurovascular structures. You expose the humeral head after detaching the subscapularis. You then replace that glenoid with a polyethylene component. So you're replacing the articular cartilage with plastic. You take off the head, and then you then put on a smooth metal component. Alternatively, when your tires have worn out, and you've actually damaged now your rotors, and you have to change, and the brakes, well, then you now have a more advanced situations where you have what's called cuff tear arthropathy, because the rotator cuff is not working, and it has certain distinct features. And the challenges are that there are multiple different surgical options, but what the current treatment is that you then replace it with a different type of ball and socket, with a different type of joint replacement. But the reason why we actually work on biological joint replacements, why we try to avoid surgery on the long as much as we can, is because there are challenges. These are wrought with failure, even in the best of hands. Those components can fail. You can have implant loosening. You have reduced joint range of motion, wear debris, cartilage failure, cuff failure, and periprosthetic fracture. These have not changed. They are good solutions in the right cases, but we're here to understand that, but also to look to the future. And with that, I'm going to now spend the last 10 minutes, or 5 to 10, I'm going to say 10 minutes, talking about what is potentially a paradigm for functional tissue engineering of articular cartilage. And this is work that I do with my friend Clark Hung. When I first started at UC Irvine, when I started, because Clark had worked so much time on chondrocytes, and we had started working on Schwann cells, and I asked Habib, like, I don't know how to culture them. And he said, don't worry about it. You worry about the mechanics. I know how to culture cells. I know how to handle that stuff, right? And true to form, like there was one of our earliest papers on optimization of Schwann cell tissue engineering with some of our youngest members who are like Dar Shafiq, who's now a shoulder surgeon in Tucson, or Fong Bui, who's an endocrinologist in Fountain Valley. Habib and I worked with him, and Habib took care of all the tissue engineering of getting the cell culture, while I worked with Clark to develop to optimize for nerve. But in the last few years, and especially as my involvement with Invitrix has increased, I have learned and start understanding back again about cartilage repair. Okay, and so these are this work is and I'm going to spend a little time explaining this as I demonstrate to you earlier in the talk about the role of a small animal model, which is absolutely necessary. But as you get further along, you're going to have to go to higher and larger animal models, and this is going to help understand why. Okay, so when you have a defect, and this is the knee, the top end is a femur, the bottom is a tibia, and you have a focal defect, meaning the entire cartilage is not destroyed, but there's a reason there's a part that's missing. You can attempt to repair it, and there are a couple of different strategies. The first strategy is using cartilage allografts to replace the articular cartilage. And the allografts are people taking cadaveric tissue or tissue from other human beings which are not responding and placing in. The alternative is to develop tissue engineered cartilage, right? And in order to do that, there are steps towards clinical translation. And the idea is basically looking at immature or mature primary cells in the best case scenario, and then mature cells which are passaged to a real world scenario, and then developing a 3D tissue model aspect. So how do you develop a cartilage allograft? Well, the standard cartilage storage model is using fetal bovine serum in a hypothermal refrigeration. And this is work actually that's been pioneered out of UC San Diego by Dr. Bugbee. And the challenges of using that are decreasing cell viability, loss of matrix components, and decreasing cell synthesis. In the process, you have a compromised clinical outcome. So the idea was that folks have done is trying to figure out to develop tissue cell protocols for preserving the allografts. What they did was a serum-free chondrogenic media, as well as using dexamethasone. And yes, that's the stuff that our president used for just recently used. And the idea of what the study was is looking at explanted immature bovine middle tissue. You basically use either the standard FBS medium or chondrogenic medium, do mechanical testing, and then what we're going to look at the biomechanical composition, look at the histology, and figure out what actually is happening. And here is in the process. These are once again looking at the difference of the different types of media. And as you're doing this, what you see, we compare the top. We look at the top versus the bottom. That they're in the non-chondrogenic media, there's a lower mechanical stiffness and the dilution of the matrix components, and there's more cell division instead of extracellular matrix synthesis. So that means that cartilage is not as useful for what we want. The chondrogenic media, which is to help grow them, actually helps improve with the clinical utilization. It allows you to produce a much stronger and better articular cartilage, and produces cells that are viable. And when mechanical testing is done, it showed it's much more robust. Now, one of the things that we have to do is that the pictures on the left, as we compare back, there are two primary large animal models, and especially for osteoarthritis. They're either the horse models or the dog models. And the canine models, and I apologize to the animal lovers in the room, but you know, it's either that or we have to do it on orphans and ex-wives, and that's probably not the right thing to do. So so we do our experimentation when we want to go to the FDA. We use large canine models, and so what ends up happening is this is an example of what we end up doing. Is that so? This is a 7-year-old dog who was injured in a trial. He had a traumatic ACL injury, a canine cruciate ligament tear. He had 4 previous surgeries, and they had all failed. right? So he was considering being euthanized simply because there was nothing, he was just in too much pain. The testing, this is in my friend Dr. Cook's lab, and these are pictures where they do they assess the preoperative disability and a certain amount of walking track analysis. When they then did, this is the grafting repair, and when you looked at it, this is his post-operative success when you see out, and here's what he's like raising that leg out and knee, right? So the idea is you actually have to assess things before you're going to implant in humans, small animals, large animals. What we showed in this particular study was that the chemically defined medium proved to be more effective than the regular for cartilage storage. This led to improved functional properties. You can then use this, to store the allografts. And this directly translated to human graft testing with a tissue bank license. And that tissue bank is basically of how you store the allograft and what you're doing with that. And these are incredibly important. So now, what's the next step, right? The next step about this is you want to look and see how you're actually going to develop, how are you actually going to move and modulate that osteoarthritic joint and making a healthy joint. And the concept of tissue engineering. So if you take away nothing about the concept of tissue engineering, this top part here is the most important. Tissue engineering involves cells, the scaffolding, and the environment. Okay? The cells for this are the chondrocytes. are the chondrocytes. The scaffolding, when we do it, is an agarose hydrogel. The environment is basically the chemical stimuli that are provided, so that we can then produce articular cartilage. There's a combination also apply physical stimuli and deformational loading, and these help to define and push the articular cartilage in a particular direction. Now, a little bit about that scaffolding that is used. Okay, so it's Agarose hydrogel is a clear thermoreversible hydrogel made of polysaccharides. There's a lot of basic science and tissue engineering on it, and it can show that you can load to the level of 10% deformation at 1 Hz almost immediately. The study they did was, and the hypothesis was looking at physiologic loading enhances chondrocyte biosynthetic activities in development of functional tissue engineering. The basic science leads to tissue engineering. Can we make better tissue, and can we make it faster? And can we precondition those cells for an environment? And so what we did was looked at that articular cartilage, loaded it in a very clearly defined manner, and then looked to see how much it could tolerate and what it could happen. Did a large animal study at Missouri, okay, with Dr. Cook's lab. Dr. Cook is a world-renowned veterinary surgeon that does large animal models. They used large animal mongrel dogs, created defects, created tissue engineering constructs. After the surgery was done, the animals were placed in a soft cast, an arthroscopy, lameness scores, histology, cytology, indentation. And these are the in vivo studies. And what they showed, so these are the defects that were created. This is an empty region, and this is what it looks on X-ray. And this is after up top where the defects were filled and looking at it. Then there was the in vivo studies looking at lameness scoring, looking at how much they got better, and one level versus another. In vivo studies also doing histology, making sure that what this tissue actually looked like, the empty defect, implant knee, and non-surgical. A critical component of all large animal studies, which cannot be done in small animals, is being able to assess functional outcomes. When you're doing dosing studies, when you're doing early studies with small animal studies, you have to start with mice and rat to find out what the right dose is. When you then move to preclinical translation, you then go to large animal models, so you can then use the same parameters that you would test in humans, right? And so the discussion is, and I will tell you, there's a lot more fidelity in large animal models. You know, if if we weren't using dog models and we use ex-wives, well, my ex-wife complains about everything. So no matter what I say, she's always going to be complaining. So I can't really use that as a gauge of efficacy of my behavior or treatment. Dogs, on the other hand, when you do that, they follow a very distinct thing. And so it's a much more objective model, and we use that on certain levels. So in this study, what we're showing is that loading the cartilage actually made a difference. And why is that important? Is that the goal is when you're putting in an osteochondral graft and you then trying to do a one-to-one graft aspect, you want to create tissue engineering constructs. And those constructs are custom-made for each defect. When you want to look at it at a next level, you have to do a scaling up. You create three-dimensional models with 3D printing. You then are going to grow the cells within certain scaffolding. And these are projects where multi-university collaborative work between Columbia University, Missouri, Colorado, and whatnot. And we looked at, this is the pre-op, look at the post-op, and what you just see is worn out tire, surgery, and this is what the post-op looks like. And is the idea, can you actually replace the entire joint? Right? And that's what the long-term goal is. Much of this work is funded by the NIH, both for Clark's lab as well as my lab. And with that, I wanted to welcome you to this current version of Invitrix's scientific program. This is our 4th annual meeting where our goal is to help educate and show that we are on the cutting edge of contributing to the advancement of the field, and that you feel comfortable knowing that we have a sustained commitment to helping our patients, which has been long-standing in nature. Thank you for your time and attention. So with that, we have some time before the break to answer questions. If you have any questions, please don't hesitate to ask, whether it's animal models, cartilage, joint replacements. I tell my sons I know a lot about a lot. The only 2 things I know absolutely nothing about is fixing a car and women. So anything beyond those 2 things you can ask me about. Yes, Dr. Hisham.
Thanks, Martin. Very, very nice presentation. I really like it. I want to ask you about the culture characteristics. Is there any relation between the culture characteristics when you apply to dogs and the amount of pressure in the mold that basically generated to do that kind of replacement?
So it's a wonderful, wonderful question. And what Dr. Hisham is asking is that what is most important when you're producing a model? Is it the actual solution and that you're placing in the tissue culture media, or is it the functional loading or mechanical? And the answer is it's both. One of the reasons that the lab at Columbia has, and that's one of the things that we learned, and Habib and I learned many years ago when we were doing peripheral nerve tissue engineering, is that if you do not incorporate the mechanical loading into the design of your tissue engineering product, it's going to doom to fail, right? Homeostasis, like when we look at things under a microscope, or it's a snapshot, it's a one-time period of time. Cells respond to their environment. So when you are creating, when you're creating a construct, that construct, without a doubt, has to be responsive to mechanical stimulant, and now even that mechanical stimulation. So one of the things that very first project that Habib and I were doing, we were looking at growing Schwann cells on glass slides, and we were looking at collagen and as one of the substrates. And Habib's idea was like, well, wait a second, why don't we look at polylysine? Remember that? And he threw out a variety of different other proteoglycans. What we found was the proteins and the cell adherence was different based upon mechanical loading. The mechanical loading was the same, but if you change the protein, it would change. And then really the answer to that is that you just have to be cognizant of that and incorporate it based upon what your design characteristics are. Anyone else? If not, thank you so much for your time, and we'll go to a little break right now. So I have, truthfully, the very distinct honor and privilege of introducing our next speaker. When we talk about the commitment that Invitrix has to cell therapy and regenerative and addressing clinical problems, nothing could showcase this better than the addition of our next speaker. When COVID, right around the time of when COVID-19 was hitting the world in November, December, our CEO had just come back from China, and he very much had realized that this was likely going to be a larger scale problem, and wanted to see how we at Invitrix could help contribute to advancing the field and understanding what's going on. Recognizing, and that part of being a smart CEO and being a company that's progressive and pivots, is recognizing where your skill sets are and where they're not. And we recognized at Invitrix that we did not have the expertise that we require to enter this space. With doing our due diligence, we found an extraordinary individual that basically is in Southern California, who worked at USC, the director of the bone marrow transplant program, the fellowship coordinator, who ran multi-center clinical trials on used cell-based therapy for hematological disorders. And this individual himself runs his own laboratory, is a dynamic speaker, consults for the FDA, helps design, participate in clinical trials. And as we at Invitrix thought we're exploring COVID-19, developing a cord blood bank, our CEO took the leap, and he's not shy, as most of you know, and began the dialogue. And over the course of the last few months, Dr. Hisham Abdelazim joined our team, and I'm proud to say that he's one of my new friends, and as a tired old man, it's nice to have new friends to invigorate and excite you with new ideas. So I'm very much looking forward to his talk. Dr. Hisham.
Thank you, Ranjan, very much for the introduction. I definitely have new friends, whether you, Habib, or the rest of the members of the company. And before I go into my talk, I really would like to credit our CEO for being visionary to expand all of the areas and the avenues for the cell therapy, not only to limit it to regenerative medicine, but also to other applications, including hematological, oncological application, and having the vision for exploring various processes of manufacturing that will closely ties to the outcome for utilization, whether in regenerative medicine or in therapeutic applications. In my talk, I'm going to talk basically about, all of you have heard about CD19 CAR T cell therapy, or Kymriah, the drug that every dose of it costs $400,000 for just an infusion, not the hospital cost, not anything else. And it made the headline news for basically giving new life for patients who are considered terminal or basically have no other option at this point. So my outline of the talk will talk about the short outcomes of CD19 CAR T cells, which is the famous product that you might heard it with different names in the news, the long-term outcomes, and basically the shortfall of this approach, which is the CD19 escape and its mechanisms, and then strategies to overcome CD19 escape, and in clinic co-targeting for CD19, 22, and what's next up, which is triphasic targeting of 19, 20, and 22. And then summary and some unanswered questions. For me, my lab has been focusing into different areas of cell therapy, but this is the current focus of the lab, which is basically developing the next step or next generation of CAR T cells. And the same platform is applicable if you want to use it for solid tumors or for any other purposes. Some of it would translate also in non-cancer related purposes. So this is the famous Kymriah, which is the CD19 CAR that got approved by FDA and made the news, and it's basically the first gene therapy approved for clinical use in the United States, After initially it was approved for ALL, followed by this, or acute lymphoblastic leukemia, followed by now approval in lymphoma, followed by the second approved product, which is called Escarta, which is a different version of the same product using a different way of manufacturing. This is basically a slide that depicts the outcome of the use of the current CD19 CAR. Most of you are familiar with this, that basically there is a significant, most of the patients who got treatment across the different clinical trial, the majority of them will go into a complete remission, and it's an MRD negative remission. And MRD is a very sensitive method to look if the patient does have any residual leukemia cells that you cannot find by microscope. But collectively, whatever version of this product you use, the event-free survival long-term at year to year and a half is about 50%. And why is this? This is because of the presence of something called CD19 CAR T cell relapse, and there are different reasons for relapse or recurrence of the disease after the use of CAR T cell product. Looking collectively at the studies, approximately half of the patient would relapse, and approximately half of those relapse are because of CD19 negative escape. CD19 negative escape, those CAR T cells are basically directed toward targeting a surface expression of CD19 on the cells of the cancer cells. And with the loss of the target, those cells become ineffective because they are selectively targeting to attack this antigen. There are multiple reasons for basically this CD19 escape, and the mechanisms of escape could be an epitope loss, which means a point mutation that lead to loss of the expression of the extracellular part of the CD19. And what does that mean? That the target cells no longer able to find the target, although they do exist. The second possible mechanism is basically an alternate, and this can happen through alternate splicing. The second part is basically defective membrane transport that lead to abnormalities in the expression of the target. So the target is expressed, but despite that the target is expressed, it's expressed in a different way, that the CAR T cells no longer recognize this target. And then you have the CD19 negative target, which basically the target is completely lost after previous treatment. It's a mechanism that the cancer become more and more smart and find a way to basically evade or overcome the primary disease. So there is a very nice paper that was published by Michel Sedeling group showing that basically the mechanisms of CD19 escape include also reversible antigen escape or trogocytosis. What's trogocytosis? It's basically when the CAR T cell attack the target and engage with the target, it basically nipple on the surface of the cell. And when you nipple on the surface of the cell, you decrease the antigen density on the expression of the cell, which means subsequent to this, your residual CAR T cells are not able to find a threshold of antigen enough to attack those leukemia cells and get rid of them. And this mechanism could be basically offsetted by a cooperative killing, which means multi-targeting or combinatorial targeting. So multiple publications have shown after this visiting or revisiting the exclusivity of CD19. At the current time, the only effective gene therapy product for hematological malignancy thought initially to be CD19, but there are multiple research that showed up that you could target things like TSLP, or you could do a combination targeting of CD19 and CD123, or you could target CD22, which is another surface marker that's commonly expressed in this type of leukemia. This slide basically goes over the different surface antigen targets for basically leukemia, and basically this could be targeted by either monoclonal antibodies or basically CAR T cells. And the whole idea is combinatorial targeting, or targeting different antigens on the surface of the cell, might overcome the problem of antigen escape. Basically, when a CAR T cell engage on with CD19, it basically stimulates ADCC. The same thing could happen, for example, with a monoclonal antibody available in the market called blinatumomab, which basically tether the T cells directly to the CD19 leukemia, and the only problem with it that the effect of it is transient compared to CAR T cells. The next part I wanted to talk about is CD22 targeting, which is a different marker or different engine that's being targeted with CAR T cells, and is expressed in the majority in the surface of the majority of adult and pediatric leukemias, ALL, and lymphomas. This is the initial publication in Nature Medicine, and targeting this antigen resulted in 57% remission rate and about 43% MRD rate. MRD is a way to look at the very minute amount of malignant cells that you can't see by microscope, and if you get rid of those MRD, you are likely to be cured. If there is any residual cells, it's a matter of time before these cells grow again and cause a problem. Now, the problem with this targeting is it results on CD20 density loss, and the survival is limited to an approximately a median survival somewhere 168 days. After this, the majority of the patient would relapse. What does that mean? That means basically this cannot be used as a terminal treatment. Taking you through basically the concept of the design of what I've been working on for some time, and basically hoping to take that into a clinical trial. If you look at the primary B-cell ALL or acute lymphoblastic leukemia or lymphoma, which is more common in adult, this is actual patient samples. You could see there is heterogeneity of the expression of CD19, 20, and 22. Every color coded is basically for an antigen, but there is an area of interaction between the three. If we apply that to the concept of multiplex CAR T cell platform, there are multiple approaches that can be used. The first one is basically carpool. What's carpool means? Means instead of basically infusing cells that are going to attack CD19 only, you are infusing a mixture of cells. Some of them will attack CD19 and the other will attack CD22. Means two types of cells that attack different antigens at the same time. Or bispecific CAR. Bispecific CAR is basically when you do have a CAR T cell that expresses more than one antigen binding site on the surface of the cell. Means generating a single CAR T cell that can attack with two methods, the 19 and 22, 19, 20, or something like this. And there is something called STAN-CAR, which is another further step down the road. It allows some selective attack of the cancer cell by basically adding synergistic molecule to the equation, like IL-12, for example, or IL-13. RA2. Looking on what's published so far, combinatorial clinical trial. With the carpool trial, there is one publication in Blood from this year, and this is basically a combination of infusing of CD19 and 22 CAR T cells cocktail, and you could see the antigen loss was reported only on one patient, compared to 50% of patients where you are using only single targeting. Another experiment in basically TAN-CAR, which is co-targeting of CD19 and 22, and in this case complete remission was achieved in this early trial in 4 out of 5 patients of CAR-naive patients, but the expansion of those CARs were limited and the persistence were limited. Means the chance of using this as a terminal treatment is also limited. Looking in my lab, we looked at different relapsed B-cell ALL, and you could clearly see that they do exhibit heterogeneous antigen expression. Those are primary patient samples, and here we are looking by flow the percent of CD19, 19, 20, 19, 22. The whole idea I'm trying to show here that there is a heterogeneous expression on the surface of the leukemia cells or the lymphoma cells. So the whole idea, if you do a combinatorial antigen targeting, then your chance of basically missing one of the target is much less. Again, this is basically the antigen expression for basically patients who got treated with CD19 directed therapy, whether Carticel or blinatumomab, and you could clearly see here that some of the patients would lose CD19 expression completely, which makes the traditional FDA-approved Carticels, Kymriah, not effective anymore. They downregulate CD20 and 22. However, despite this downregulation, they are still targetable levels. This is basically a flow graph. If you could follow with me, this is looking in a primary CD19 negative cells expressing targetable level of different antigen. So this is the same patient before and after. So this is pre-CD19 Carticel therapy treatment. You could see there is a bright expression of CD19. It's lost. For CD20 and 22, they were there, but they became dim. Similar situation with the other patient. However, I'm going to show you using a combinatorial antigen targeting, you could offset that problem, and those combinatorial antigen targeting would allow you to effectively target that low-level antigen expression. In the lab, there is a limitation of the availability of primary human samples. So to recapitulate what happens, normally my lab developed a CRISPR technology that induced CD19 loss, which is basically a method where you genetically engineer the stem cells or the leukemia cells to knock down the expression of CD19. So you are trying to recapitulate the situation where you treat patients with CD19 directed therapy, and you could clearly see this is normalized. This is basically CD19 positive cells. This is basically after knockdown with the CRISPR technology. You could see CD20 and CD22, they are still there, even you knock down the CD19 expression. And this is the % expression by flow cytometry. So after this introduction, the hypothesis of what I'm going to talk about is targeting of CD19, 20, and 22 will overcome CD19 antigen escape, resulting in an enhanced anti-tumor activity. So which platform to use? Separate CAR molecules, and what are the data on this? So if we look at the CAR multiplex platform, which I talked about before, is basically the CAR pool, the biCAR, and the tank CAR. If you use the Boolean logic in action, the more you increase your targeting spread or target more antigens rather than 1, if you target 2, if you target 3, the higher chance to have an effective therapy that will eradicate the disease. This is basically our approach, which is basically very similar to the approaches used in regenerative medicine, with an exception of the last step of the genetic modification, depending on the use. You do a collection, and that collection could be done from the same patient or the donor with basically pheresis or peripheral blood. And then you separate the T cells in the lab. They undergo transduction, which means introduction of a gene, basically through viral transduction. And that gene result that the T cell will express 3 surface molecules on its surface. CD19, 22, and 20 means triCAR, means you can attack 3 antigens at the same time. Those cells undergo rapid expansion in the lab, and then you re-infuse them again into the patient. So this is basically a triCAR design for efficacy evaluation. Again, with this design, conceptually, this should be effective in CD19 positive disease, similar to the FDA-approved product like the Kymriah or the Ascarta that's available as a standard of care now. Because the CAR-T cells generated still express CD19, but it should be also effective in CD19 negative relapse or antigen escape, which is the very well-known or problematic issue that happens with the treatment with the current CAR-T cell product. So in collaboration with other colleagues around the country, including at Baylor College of Medicine, we designed a triCAR transgene, and the triCAR transgene include a cassette that expresses CD22, 20, and 19. And this is actually a viral vector which translates into this. The viral vector is used to modify the normal T cells to induce the expression of CD19, 20, and 22. And this is how it would look like. We have shown that the 3 CARs expressed with this viral vector that designed in my lab basically is able to be expressed, the 3 molecules in primary T cell ALL. Again, this is CD19 CAR or single CAR. This is the tri-CAR, and it expressed CD19, expressed CD20, and expressed CD22. And this is on T cells, so all of those events are gated off CD3 positive cells. We looked into characterization of the CAR T cell product, and you could see that the majority of the cells that are produced with this technology are basically CD8 positive cells, T cells, which is very similar, for example, to the current products in the market. We looked at the phenotype of those cells because we wanted to know that those cells are young, energetic, or they will go into senescence quickly, and you could clearly see that the majority are effector type with some naive and central memory T cells. The fact that you have more central memory and more naive T cells means those cells have much more capability or potential to continue for or survive for a much longer time, to be able to have this as a potential terminal treatment. Basically, the next logical question, are tri-CAR T cells are effective against primary BALL? When I mean primary, means CD19 positive or patients who never got CD19 directed therapy on the FDA approved product now. And the tri-CAR cell exhibit targeted specificity. And I'm going to show you an experiment that was done on my lab using something called Excelligent technology. Briefly, to understand what is that technology is, you culture the cells on a specific plate that basically have a current going into the bottom, and the more the impedance in the current means the cells are growing and confluent onto the bottom of the plate. When the cell die, they detach from the bottom of the plate, so there is no impedance, there is less impedance in the color in the current. This is advantageous over the standard monitoring with trypan blue or with counting, because this would allow you to dynamically and constantly measure the viability and the effect of survival on the cells. You could clearly see here, this is measured with a DNA index or cell index, with basically, this is the non-transduced cells, this is the standard CD19 CAR T cells, and this is basically the tri-CAR T cells. For a CD19 positive target, the non-transduced T cells, the cells are surviving fine. So basically, the impedance haven't dropped, but it dropped significantly or equally with the tri-CAR versus the single CD19 CAR, indicating that at least that the tri-CAR is as effective as the current approved CD19 CAR. If you look at CD20 and CD22 targets alone, you could clearly see there is no difference between the control and the CD19 CAR, but there is efficacy for the tri-CAR, and the same is applicable when you look for the CD22 CAR. What I'm trying to show you here, at least in vitro or in the culture, there is the CD19 CAR or the tri-CAR behave similarly to the standard of care CD19 CAR T cells, while when you have a target that express only CD20 or CD22, there was an exclusive activity for the tri-CAR compared to the CD19 CAR. We wanted basically to look at the percent lysis or killing with basically a different assay, and you could clearly see if you express the 3 targets, the tri-CAR performed better compared to the CD19 CAR, while the control have not produced any lysis or killing of the cells. And the more expression or brighter expression, the affected basically the CD19 CAR, but it did not really affect the tri-CAR. We went one step further and we wanted to look at the immune synapses. Or what are the immune synapses? When the CAR T cell engage with the leukemia cells, they form something called immune synapses to perform interaction with the target. And we want to characterize that. And with this method that was developed with sequential gating, you could see here a CAR T cell is attacking a leukemia cell, and you could measure the distance between the two nuclei in every point of contact to see how much strong is the contact, as a strong contact indicating more affinity to the target. Looking at this in a statistical method, this is quantification of the immune synapses formed, and you could clearly see that the TriCAR was significantly better than the non-transduced as expected, but with the CD19 target, it was similar to the it was significantly better compared to the CD19 target. If you quantification of the actin stain on the synapses, and actin basically is a protein that basically get activated when the T cell attacked the target. You could clearly see here that there was a significant superiority for the TriCAR compared to the CD19 CAR, and definitely for the single CAR compared to the CD19 CAR compared to the non-transduced CAR. So the idea here that the TriCAR T cells from more polarized immunological synapse with BALL, and this is basically a measure of actin polymerization, showing that with the TriCAR there is significantly higher polymerization compared to the CD19 CAR. We looked after this into something called the timing assay, and I'm going to show you something cool, hopefully a video showing live the CAR T cells attacking the leukemia cells. Basically, there are three things. First of all, when the CAR T cells look for the target, they take time to conjugate with the target, attack the target, and detach, and then after to go to the next target, and death of the target. So I don't know if you could follow what I'm trying to say. This is CAR T cell, this is leukemia cells, and you could see it's basically the leukemia cell is attacking the CAR T cells, the CAR T cells attacking the leukemia cells, and finally it killed one and is still struggling with the other one. And this is basically with time-lapse microscopy showing directly what's happened on a microscopic level. This is the different parameters that we look into it, and it basically three things. One of them is the T-seek, which is time to seek the target, and you could basically see that although CD19 have a shorter T-seek, which means it reached the target quicker, at the end the contact with the target is much longer with the TriCAR, and basically the time to death, which means the time from the start of the attacking the target to the target dying, which is the leukemia, is much shorter with the TriCAR. This is a very simple basically characterization of this, and you could see here that the TriCAR have performed significantly better. 2 means attacking 2 in a specific time frame or 2 targets. 31 of the cells attacked multiple targets or more than 2 targets in a specific time frame, compared to the 21% for the CD19. And it's the same thing for 1 target versus basically for the CD19 versus the TriCAR. So that basically alludes that the TriCAR are a better serial killer when it comes to interaction with leukemia. This is all in the culture, so we wanted to move after this to animal models, or testing this is an animal, which is really the most close things that recapitulate what happens in human. So what we did, we wanted to ask the question, if we have a leukemia mouse model, is the CAR T cells are going to perform similar to the standard of care CD19 CAR if you inject the animal with a CD19 positive disease? And in this experiment, we used NSG mice. This is a primary human sample. NSG mice are immune deficient mice that will accept any graft that you put it into it. The mice were established, and the leukemia cells were engineered in a way that they glow something called luciferase, that you could image them with an X-ray from outside and see how much tumor burden without sacrificing the mice. You will sacrifice them at the end, but until you sacrifice them, you could dynamically measure the leukemia burden increase and progress. Once the leukemia was established here, the CAR T cells were injected, and then we followed them with something called bioluminescent imaging. This is the bioluminescent imaging data, and instead of showing you pictures of the mice, I decided to do that in a quantitative method, which something called the radius, and the quantitative method measure the amount of emission from every mice, and that would translate into the tumor burden. And you could clearly see here, after injection of the CAR T cells, there is a stabilization, then following after this an eradication of the disease compared to control, which is T cells. But at least the CD19 CAR versus the tri-CAR, they performed similar on CD19 positive disease. And this is the probability of survival of the mice with this kind of an experiment. And you could see that the tri-CAR and the CD19 CAR had identical time to progression compared to the non-transduced or the control CAR. Again, we want to look at basically the efficacy on relapsed BALL, which basically patients who have lost CD19 expression and don't have the target anymore. And ask the question, do tri-CAR T cells maintain efficacy in the absence of CD19 expression? And we wanted to model CD19 antigen escape that happened in humans after basically treating with the CD19 positive product, and ask 3 questions: overexpression of antigens on cell line, CD19 knockout on the CRISPR-Cas technology, the slide that I showed you earlier, and on primary relapse samples. This is basically overexpression of antigens in the UA cells that basically you could see that this is artificially generating a cell line that basically does not express CD19 but express CD20 and CD22. And this is similar experiment that I showed you before, which is the data in vitro, in tissue culture. When you culture a target that expressed the 3 targets, the 2 vector, the single CD19 or the tri-CAR perform similarly. When you have CD19 negative disease, which what happened when you relapse after CAR T cells, there is no efficacy of the CD19 CAR T cell product, which is currently approved, compared to the tri-CAR, where you could see a complete eradication of the disease. When you do mixture of both, you could see a partial response attributed to the CD19 positive target, and the rest are not responding because of the CD19 negative disease, compared to the tri-CAR where both targets responded. What I'm trying to say here that this approach is as effective as the current CD19 CAR, at least in the CD19 positive disease, but it's exclusively effective for the CD19 negative disease. And this is again percent lysis for in vitro culture, and you could clearly see this is a primary human sample, and this is CD19 positive disease. Both of them are producing killing. If you do a knockout, basically you do not have any efficacy for the CD19, and again those 2 other relapse sample with CD19 negative disease. If you add the tri-CAR, this is the red bar, you could clearly see how much is the killing effect, which was statistically significant with all of those primary human samples. We looked into the functional assay. When the interaction between the CAR happened and the target, inflammation happens, similar to what happened at COVID. Basically, you get a release of something called interferon gamma and TNF alpha, and this is a surrogate for the either if the pathogen attacking the cells, in case of, for example, COVID, or basically of the CAR T cells attacking the leukemia. It's exactly similar mechanism, but for different causes. And you could see here that the amount of interferon gamma release with the tri-CAR is much higher compared to the CD19 CAR, indicating that it does have a much higher activity, at least in vitro. If you do that on the absence of CD19, you could see basically that the tri-CAR, you could see that basically only the tri-CAR have efficacy in the absence of CD19 or generating interferon gamma. I'm going to skip those slides for the sake of time and go into one other approach that we have used. We have used something called single cell proteomics to generate something called polyfunctionality index. Polyfunctionality index predicted in clinical trial the response to CAR T cells, and this is published by other groups. When applying this method to basically our product. This is basically the CD9 Raji cells, which are CD19 positive disease, and you could clearly see the CD19 CAR is effective. The CD19 Tri-CAR is effective, although the CD19 Tri-CAR was more effective. If you apply it to the knockout, to recapitulate basically what happened with the escape knockout means deleting CD19 expression, you could see that the Tri-CAR is exclusively effective compared to basically the CD19 CAR, which there is no difference between the control and the CD19 CAR, while you have a significant efficacy compared to the with the Tri-CAR. And this is as close as it can get before going into a clinical trial. We took this after this into human applications. Same experiment I talked about before, NSG mice. But in this case, the mice was transplanted with a CD19 negative CAR T cells. Means CAR T cells that lost expression of CD19 or CD19 was deleted off them after the tumor was established, and you could measure the amount of the tumor by imaging from outside, by bioluminescence imaging, before sacrificing the mice. You inject the CAR T cells, and then you keep taking X-rays or images at different intervals. And the amount of emission from those X-ray or bioluminescent could be basically correlated with the disease burden after this. This is basically the amount of disease burden with this method. And you could see here that the first one or the first two lines on top of each other are the non-transduced and the CD19 CAR. They are almost identical, indicating no efficacy for CD19 standard CAR in CD19 negative disease as expected. However, with the CAR T cells, there is basically control of the disease once the CAR T cell proliferate and start to expand. If you put that into a survival curve, the overall survival for the mice that got the Tri-CAR was 100%, compared to progressive survival ending into complete death of the mice if they are injected with non-transduced control or with the standard CD19 CAR after establishing of a CD19 negative leukemia. So in summary, I hope I have shown you efficacy of the Tri-CAR against the primary ALL, improved serial killing with the timing assay, and greater cell activity with the higher affinity of formation of an immune synapses, and the efficacy in vitro of the Tri-CAR in killing CD19 negative disease, and the improved efficacy in vivo in the absence of CD19 CAR as evidenced by the tumor burden and basically the probability of survival in mice. What are the conclusions from what I presented? The Tri-CAR cell provide efficacy in CD19 positive and CD19 negative disease. Are they better suited for salvage or upfront to replace the current FDA approved standard? That's a question that needs to be answered in a clinical trial. The sure thing is that targeting 3 tumor antigens expanded the Tri-CAR utility in more patients with less, with hopefully less antigen escape observed or none. What influence with the and which escape mechanism will take place, if any, if using that product? Is there any patient specifics? Epigenetics are involved. And this is basically, we published this in Leukemia a few months ago, and this is from my lab in collaboration with my colleagues around the country. And we are working now into getting an IND to move that into a clinical trial to answer all of those questions. And with this, it wouldn't pass before talking about my, it's not really a one-man show or a one-lab show. Science now basically have to be done in a collaborative manner. So this is actually a collaboration between my group at USC and my lab, and basically the lab of my colleague Dr. Ahmed at Baylor College of Medicine, University of Houston, and the Center for Cell and Gene Therapy, also at Texas. And this was, and I would like also to acknowledge the funding organizations. And with this, I would conclude. I hope it wasn't too technical or very difficult to follow.
the non-clinical, non-scientific members of the audience, if you would sort of give us a few minutes of what I call a Reader's Digest of target immunocell therapy or CAR-T technology. I would really appreciate for you to, in a simple term, share with us where this business is and where things are going.
So the very simple idea of the CAR-T cells, you take the patient's own cells, not another cells from a donor, because you don't have the problem of rejection, and then you redirect those cells to become magical, attacking a specific target. But that target has to be only on the surface of the cancer. So you do that by genetic engineering of the T cells to express a molecule that specifically target that antigen. So you could think of it as a magic bullet that basically, instead of the standard chemotherapy where you basically hit everything, including the cancer cells, you are re-educating and directing your own T cells to attack only the cancer cells, and you do not have an off-target attack into the other antigens. Well, the T cells are re-educated. The T cells don't really attack anything other than what they are educated to attack with. So that's basically the simple idea. And as much as the conceptually it's a simple, as you could see, it has a lot of complications. And this application is not only in cancer. The same thing could be applied into multiple areas, like for example, in infectious diseases. If you educate the specific T cells against specific antigen that exists into a certain bacteria or a certain fungus, they will attack that fungus and will kill it without causing an off-target effect. The same for COVID, for example. If you are able to identify a specific target in the COVID and you generate CAR-T cells that attack specifically the COVID, then they will attack that. There are other applications in regenerative medicine. For this, for the sake of time, because it wasn't off the topic, I didn't talk about it. But there is, for example, a way where you could generate your CAR-T cells not only to attack, but to secrete a specific material, like, for example, one of the interleukin that promote the growth and the expansion of your of the person's own stem cells, which does have a significant implication into the regenerative medicine applications. So you could think of this, although I talked about cancer, as a tool that could be used for various areas of basically of cell therapy. And instead of using a hammer or using a broader approach, you are basically trying to narrow it and use a very precise method to achieve your goal versus a broad hammer to basically hammer everything to achieve your goal. So instead of demolishing a whole building, you are trying basically to be very accurate that you could demolish only the small part that you need to demolish and rebuild again.
Dr. Isham, that was a great presentation. Thank you so much. Good technical question. So the trial card we showed mostly was CD4. It was CD8 versus CD4. Was it specifically like you designed it, stimulated that way, or it was random?
No, this was random, and this is actually found due to culture characteristics. And it's not different actually than the two commercially approved CAR for now. 90% of Kymriah Novartis product is about CD8, about 80% of the Yescarta is CD8. There are people who are saying that if you split the cells from the beginning and do a separate modification and infuse a mix of 4 and 8, you might get a different, better response, but that remained to be seen. But that wasn't really intentionally designed. It's the cultural condition that drives CD8 expansion.
So as of now, we don't know the best ratio, CD4 versus CD8 for trials, like 1-to-1 ratio, we don't know that, right?
There are trials. There is a PLAT-02 trial that in Seattle that trying to answer that question by mixing 1-to-1 ratio.
I see.
But all of the FDA-approved products and the majority of even the non-approved products in the market are basically
CD8.
Are basically CD8.
I see. Thank you so much.
I have a simple question, which is, so do you think that CAR T cell therapy will be broadly accepted to beyond non-hematological disorders, cancers? Meaning, what do you think the role of it is for solid organ malignancies?
So at the current time, there is probably more than 100 trials for solid organ malignancies. The situation in solid organ malignancies is a little bit more complicated because it's the microenvironment. The tumor itself does have a lot of inhibitors that inhibit the action of the CAR T cells. So a more sophisticated design for a CAR T cell that induce local secretion of, for example, IL-12 or IL-13 alpha, or basically combining the CAR T cell with a T cell that expresses a PD-1 blocker on the surface of it will improve that. But I think the future is we're going to reach that. At the current time, there are multiple trials which are very promising, but there isn't any FDA-approved product. But I think we will be there within the next few years. Okay, if there is no additional questions, thank you.
So, like all good CEOs, they are always, the making of a good CEO is recognizing talent and skirting a variety of different opportunities to find individuals. So one of the things Habib has done throughout the time is he visits universities, he goes to labs to learn and to scout for talent. Habib, when was the first time you met Milad? His thesis proposal or what stage?
Yes, at that time, Milad was a budding scientist at UCI. And I went to sit down to his defense. The game plan was like my daughter. My daughter just became an attorney. I asked her to come and work for the company. She said, "Dad, let me go make all of the mistakes somewhere else." So we left Milad to go to City of Hope for 2 years to make all his mistakes to come and work.
Right. The point is, Habib recognized talent early. He went to his thesis defense. It's not the normal place of where you go find talent, right? And so that dialogue was initiated. And Milad, as I've gotten to know over the past few months, is an exceptional scientist, an extraordinary individual, family man, devoted father and wife, and an incredible member of the Invitrix team. When he got his PhD, it was in the field of exosomes. He was on the ground floor and helped and has been a part of that field for over a decade. That's what his work has been a part of. He's then gone on to City of Hope, gained some experience, and has been an integral member of Invitrix over the last several months to help direct not only product manufacturing and the day-to-day operations, but primarily being part of the vision and direction of how Invitrix is an integral part of cell therapy. With that, please join me in welcoming Milad Razifat.
Thank you so much, Dr. Gupta, for the kind introduction. Good morning, everyone. So it's a great pleasure to be here and lucky to be working with a great team at Invitrix. And pleasure to be here. So on the barrier between you and lunch. So if you listen carefully, it's going to be short presentation, I promise. If not, it's going to be 2.5 to 3 hours presentation. So make sure you comply. Let me pull up the presentation. Also, disclosure, I walk a lot during presentation. So in case front rows, if you feel nausea, let me know so I slow down. I don't want anybody call 911. I hate Windows. Okay, so today I'll be talking about a little bit on the science part of the exosome, extracellular vesicles. What are those blebs? Also, I would like to touch on a little bit on the challenges on the manufacturing of these vesicles. How can we develop therapies based off exosome? Also, I would like to touch on how can we use this knowledge to develop exosomal therapeutics. So the question is, what are these exosomes and what is the role of these vesicles? So we know that communication is a global phenomenon. We all as human, we communicate verbally through text messages, and at Invitrix, we communicate a lot with WeChat. So that I learned from my boss. So yeah, anyway, whatever scenario software you use, we all communicate, right? So for a long time, we thought that cells, when they want to communicate, like how these CAR T cells engage with the cancer, it does need direct engagement. So the cell, we call it kiss. So they come in and kiss each other. This is how this engagement and synapses are happening. Very recently, it's been discovered that cells, when they want to engage, is not going to be like direct cell-to-cell communication. They can have long-distance communication, sending like text message, Twitter, that basically they are sending these blebs that we call it extracellular vesicles or exosome, and this is how they are communicating. So basically, this is another way of cell-to-cell communication. You may ask, okay, how come it's been really discovered very recently? These vesicles have been around for a long time. That is correct. For more than 30 years, we knew these vesicles. And the idea was that these are just mere trash bin for the cell. Whenever cell has something that they don't like it or they don't want to store it inside the cell, they put it inside these vesicles and they'll secrete it outside. So for a long time, it was considered as a trash bin. Till 2007, where Jan Lotwal, my previous co-advisor and co-mentor, discovered that they are not trash bins. Basically, this is another way of cell-to-cell communication. And what is happening is that cells talk to each other through sending these vesicles. They put tons of RNAs, RNA molecules, proteins, and different types of lipids. And this is how they communicate. So after that, the field exploded, which was not very recent, 2007 for this discovery. So after that, the field exploded, looking into the applications of these exosomal-based either diagnostics or therapeutics. So to explain a little bit more science on these vesicles, basically all cells talk to each other, for sure, like us as human. So what is happening scientifically, basically these vesicles generated inside the cell, then released to the outside. And the beauty with these vesicles is that, as I mentioned, they have different types of RNAs, they have different types of lipids, and they have proteins inside and surface receptors outside as well. And that makes it a natural, complex package to deliver a lot of information at one time. So then the question is, what is happening once these vesicles go out? How do they deliver the message? So this is my favorite slide, actually. So if you don't mind, I'm going to spend like half an hour explaining, and I'm going to have a quiz after that. So make sure you remember. I'm just kidding. So basically what is happening after releasing these vesicles, they touch the target cell. These are these vesicles, these pink one. They are different mechanism. To simplify it, they go deliver their target, their cargo to the target cell, and that is basically reprogramming or giving information to the target cell what to do or what not to do. So this is basically how the signal is, transferred. As you all know, there's a lot of efforts in developing exosomal-based therapeutics, right? So if you compare it with the whole cells, exosomes or EVs have some superior properties compared to the cell therapy. One of them is mole differentiation. So mole differentiation is that when you inject a stem cell, they get some signal, they become like say bone or fat cells, something that you don't want. They become something that really is not intended, to do. These vesicles, they are not live entities, so they don't have the ability to change. That's why it's a huge advantage in terms of the mole differentiation. And as of now, we think, that's why I put likely, we don't think they induce tumor unless they are coming from tumor cells. If they are coming from tumor cells, yes, they have the ability to induce tumor. But it's coming from like healthy cells, stem cells, normal cells, they don't have the ability, very likely, to form a tumor. One of the problems with IV injection of cell therapy, as you all know, is the a pulmonary first pass effect. When you do IV, they all go and trap into the lung, capillaries, right? So these vesicles are small, 50 nanometer to 250 nanometer. They bypass these micron size capillaries in the lung. Not to mention superior tissue penetration, and it could be off-the-shelf product. So you can have it ready whenever the patient needs it. They can be administered. Also, it's easier cryo handling and stability, which I'm going to discuss at the end of the talk. So, stem cells we do does need DMSO, right? It's a toxic ingredient that we have to use to make sure the cells do not die. But the beauty with exosome storage is that you just put water, salt and water, PBS. You can store it without any cryoprotectant. So I showed this slide last year. I don't want to repeat the whole, if for some of you have been here last year, I don't want to show you repetitive stuff, but during my PhD, we evaluated the efficacy of these stem cell exosomes to see if really they do something. There was a lot of people talking big about exosome, that they're doing X, Y, Z, but I really want to see is it true or not. So what we did, we chose an animal model, EAE model, experimental autoimmune encephalomyelitis, which is the gold standard animal model for multiple sclerosis. So what we did, we injected some toxins. So during the time, these mouse become paralyzed. Then at day 18, when these mice are completely paralyzed, we injected 1 dose of exosomes. So we injected 1 billion exosomes per mouse. Then we scored them from day 18 till day 40 to see how they are recovering. This is just one slide, just a short video of. This is the control. This is the control. This is the exosome treated one. As you can see, the exosome treated one can walk, it can also eat and drink on their own. These ones are basically ready to die. They cannot eat and drink. The walking ability is not perfect, but it's a significant, improvement. Long story short, this is what is happening with these animals. So what we did, we injected MSC, mesenchymal stem cell exosome, into this animal model. We showed that they traffic to the site of injury. The site of injury for these mice is their spinal cord, where there's a lot of inflammation. That's why they get paralyzed. So what is happening in the spinal cord? They go in, they suppress these cells we call macroglia. Macroglia, all the cells who secrete these enzymes to chop the myelin sheath. So these are bad guys. So it suppresses these bad guys. And there are some good guys, regulatory T cells, as we call them Treg. These ones in the body help to suppress the inflammation. So these exosomes induce the frequency of these cells in the spinal cord, getting more help from the body to suppress the inflammation. Also, for some, with some certain mechanism, which we don't know exactly how, they help with the remyelination processes. So mouse who had received exosome, they had more, myelin around their nerves. Then we look at a lot of RNA and proteomics data asking the question, what is really happening? What is the mechanism of action? We still do not fully understand how it is happening, but we did find a lot of anti-inflammatory molecules, RNAs and proteins inside and outside these vesicles, and many neuroprotective molecules, again, inside and outside these vesicles. This is how we are thinking as of now, that this is how they are exerting their, MOA or recovery. And basically what we found was that inflammation decreased over time, but remyelination increased. So, and we published this result in ACS Nano, which is a well-respected journal for nanomedicine. So now the question is, okay, this is all good. Now we want to bring it to the next level, to bring it to clinical trial, to see does it work in human or not. So one of the challenges in the field right now with these exosomal based therapeutics is the manufacturing. Why? Because for a small molecule drug, you can do the chemical synthesis like 10 different ways. You still get the same structure, chemically defined structure. So there are multiple ways, doesn't matter. Your final product gonna be the same. But for exosome, as a biologics, is different. Because for exosome, the process is the product. This is very important. The process is the product. So what does it mean? Basically, what it means is that what kind of cell you use to harvest your exosome from. What is the passage number? What is the cell production methodology that you use to culture cells? What is the status of the cells at the time of harvesting your EVs or exosome? What is your EV isolation methodology? How do you isolate your EV? What is your purification methodology? All these small things matters, then that determines if your final formulation gonna do something or not. So this is why it's a little bit challenging right now in the field, and many companies are trying their hardest to really optimize these exosome-based, manufacturing. So to facilitate that, I had the honor to work with a couple of world's best people in the field to put a paper together like a few years ago. The discussion back then was that, okay, if you want to push it to clinical trial, what needs to be done to really be able to comply with FDA regulation and bring it from all these preclinical settings to human? We came up with this methodology. Basically, you first, of course, have to show efficacy in animal models, such as what you saw with presentation with Dr. Isham and Dr. Gupta. You need to show efficacy. You need to show in animal models that it does something. And not to mention, you can also do some in vitro tests, to produce more data. Also, you need to know at least your MOA. Of course, no one knows the mechanism of action. It may take us 100 years to exactly decipher how exosome works in the body. So at least if you want to bring it to the FDA, you should have a rough idea of what your MOA is. So knowing these two, you have to develop a couple of tests, which is not common in the field right now. Even if it advanced a lot over the last 5 years, you need to develop your consistency assay and potency assay. Potency assay with the small molecule drugs, and consistency assay is very easy. It's difficult with exosome because we don't have established potency assay. So basically the investigators are really responsible to come up with their potency assay. Potency assay, it means that if your exosomal product is functional, if they do something, it could be whatever. Consistency, as a biologics, you know, there's a lot of batch-to-batch variation because it's a cell dry product. So basically, FDA wants you to show your product is consistent. We call it consistency assay. But if you ask FDA what kind of assay you want, they say we don't know. You develop a consistency assay, show us that your product from manufacturing all the way down, starting the cell culture to the final formulation is consistent. Basically, you have to design those, which is very difficult. So basically, after that, you can file pre-IND, IND application to the regulatory agencies, and this is the path moving forward. So now, I'm going to switch gears to more on the traditional manufacturing processes and what is the current industry standard for manufacturing these extracellular vesicles. So a lot of these, because of their size, it's 50 nanometer to 250 nanometer, is very similar to viruses, right? That's why a lot of methodology for isolation, characterization came from virology field. So basically the traditional way of exosomal isolation is ultracentrifugation. And this is considered still to be the gold standard methodology, specifically in academic settings. So basically what you do, you have your flask, hundreds of flasks. You use a special media without serum. As you know, serum is full of exosome, so you don't want to contaminate your serum exosome with your current cultures. You starve them, you collect the conditioned media, you go through serial ultracentrifugation, then you're gonna collect your exosome, right? Then you're gonna do all this quantitative or qualitative analysis to basically count the number of exosomes, see if they are doing anything functional. So this is the path, and this is the traditional way of doing it. But even for that, as I mentioned, it's really not that easy. So this is just an example. This is the extended version of previous slide where I mentioned about the challenges of the fact that the process is the product. For example, you want to have exosome-based therapeutics, let's say mesenchymal stem cell. The first question is, where do you want to get your mesenchymal stem cell? Are they coming from fat? Are they coming from bone marrow? Are they coming from umbilical cord? What is the source? That's definitely going to be giving you different product. Not to mention, how do you want to culture the cells? Are you going to be using FPS in your media, fetal bovine serum, for your culture? Or you want to use human platelet lysate? Or you want to use the chemically defined media without using any serum containing materials? Again, that's gonna have a significant difference on your final formulation. Not to mention your donor selection. You want to get it from cord blood, you want to get it from bone marrow, you want to get it from fat. What is your donor selection? What is the age? What is the genetic pool of these donor? There's definitely going to be donor to donor variation, ethnicity variation. So another challenging part is that what kind of donor selection we would have. Not to mention, as I told you before, how do you want to culture the cells? Let's say you fix all the issues till this point. You want to do 2D culture, you want to do flask, you want to do a 3D bioreactor. All these small details matters, and that leads to different product. That's why process development is very critical for exosomal-based therapeutics. This is something that I had the chance to spend over at least last 7 years trying to find what is the best, optimal scenario for developing exosomal-based therapeutics. Not to mention, again, another level of complexity. So even you fix all this stuff, how do you want to isolate exosome? You want to use ultracentrifugation. You want to use the filtration methodology that I'm going to explain. Actually, these are some of these different types of methodology for culturing cells. So we discussed this issue. The other issue is the exosome isolation. So are you going to use ultracentrifugation, or are you going to be using hollow fiber tangential flow filtration, which I'm going to explain in detail? How do you want to use it? Or you want to use other affinity-based, these are more for a smaller scale. So this is add another complexity to the scenario. So now you have to think, how do you want to isolate your exosome? So all these details matter when it comes to the manufacturing process. Then you would say, okay, that being said, we would never be able to develop a product. Is difficult, but is not impossible. So basically, if you know what you're doing, if you know your exosome, you know have a rough idea what kind of protein, RNA they have inside, you know your indication, with some try and error, developing potency assay, with manipulating some of your process development procedures, you can easily tell with your potency assay or which process is better. So there are some ways to get around these issues. So talking about manufacturing, as I mentioned, the gold standard for academia is ultracentrifugation, which is very time intensive, labor intensive, scale out, not a scale up, you cannot scale up. For these new generation technologies, is scalable, is more closed system, FDA friendly, high scale, and one of them is tangential flow filtration. So the question is, what is tangential flow filtration? When I heard the terminology a few years ago, I was thinking this is like a rocket science and shuttle kind of design. Oh, I was thinking I would love to see a TFF in real life. What is it? So basically, TFF is a pump. It's a pump with a filter. So you have your filter hollow fiber. This is your hollow fiber. You collect your conditioned media, which contains exosome, right? You pass it through these filters. So these filters have some different sizes. This is why we call it tangential, because the direction, this is the feed stream, this is the direction, and the orientation is tangential. So basically it pushes away all these non-exosomal ingredients like proteins, protein aggregates, all those stuff that are not supposedly exosome, but again, we're gonna discuss how pure that would be. So basically what it does, let's say these blue ones are proteins, it's gonna get rid of these proteins, then eventually enrich your exosomal population. So this is how we can enrich the exosomal population, but still there are going to be some growth factors inside these TFF. That's why there are many chromatography approaches to further purify these vesicles. But again, the question is, would you want it less purified or more purified? Initially, people thought that the more purified is better. That is not correct. We recently, getting to know that even if it's too pure, it may not be efficacious enough because they come in with other growth factors that you still want them to help you. But again, that depends on the depends on what kind of condition, what is your potency assay, and all those sort of details that determines, do you want to purify after TFF or not? So now talking about all these challenges, at Invitrix, as you know, we have been working on developing exosomal-based product. And in the next few slides, I just show you one example how we can use this knowledge to develop exosomal-based product. So one of the diseases that we decided to go after is dry eye disease. Why dry eye disease? Is the most common ocular surfaces in the world, and dry eye disease, as you know, is multifactorial complex disease, and inflammation is the key part of this dry eye disease. Very recently, it's been considered as an autoimmune disease. So initially, we were thinking, you know, it's going to be a mucin production, all the tear film messed up, all those gland issues. But now we know that it's a more autoimmune disease. So, and also we know that we have basically 286 million dry eye cases in the world. So there's a huge population of patients. That's why we were interested. And current therapeutics is Restasis from Allergan, and it barely really get FDA approval compared to the control. They really push it so hard because they spend millions of dollars on Restasis. They pushed it, you know, to the approval. And many, if you talk to the patients who suffer from dry eye disease, most of them they would tell you Restasis is not working. So basically, we need to really define and basically, you need to develop next generation therapeutics to be able to answer these issues. Because these dry eye disease and a lot of like multiple sclerosis, type 1 diabetes, all these autoimmune disease, all it's a complicated disease. They are multiple pathways involved in disease pathology that needs to be addressed. That's why small molecule drugs is not working very well. If you recall, I showed you exosome has different types of RNA proteins. So that's why it makes it a more suitable platform to get after complicated diseases, because initially the product is complicated. It has different ingredients that helps to target multiple pathways at the same time. That's the beauty of exosome. So then we asked, okay, what kind of cell are we going to use to harvest our exosome, and what is the approach? Basically, we knew that mesenchymal stem cell, through literature, that they have anti-inflammatory, they have anti-inflammatory capacity, they have antimicrobial function, as last year Dr. Kaplan showed some data, and we know that inducing of the growth factor goblet cells can increase with, they secrete some factors that help with the goblet cells. Also, it secrete factors that help with corneal epithelial stem cells. So then you may ask, okay, we cannot inject exosome to the surface, or you cannot put exosome as a dry eye, in an eye drop and put it on the surface. That's why the beauty of exosome come in. You drugify a stem cell. In this particular case, you can have all these advantages of mesenchymal stem cell without having the cells. You cannot put the stem cell as an eye drop, but you can get the exosome. You basically drugify a stem cell and use all these capabilities of stem cell, and you can develop exosomal-based eye drops. So what we did, we used the source, which is mesenchymal stem cell, safe and therapeutically promising. The drug, or exosome, pro-regenerative vesicles from a stem cell culture media. This is Restasis, which we're gonna kill, hopefully in the next few years. And this is your product, which is gonna be first-in-class exosomal, as eye drop. So this is gonna be hopefully the world's first biologic in form of eye drops. So how we did that, we submitted in our CGMP facility. We had these cells, we cultured it through scalable tangential flow filtration, we develop our off-the-shelf eye drop, exosomal eye drop, for the first time. So we submitted our pre-IND application. We are pushing it forward through IND application to, hopefully soon. One thing I would like to mention here is that another beauty with exosomal-based therapeutics is that you can have it off the shelf, as I mentioned. Also, you can have it as injectable form, topical, eye drop, or inhalable. That gives you the ability to target multiple diseases, such as injectable, let's say, type 1 diabetes, multiple sclerosis. You want to target COPD. You want to target skin conditions, psoriasis. You can put it as a cream. So that modality gives you the flexibility with the exosome, gives you the ability to develop different modalities based off exosome. This is another advantage of exosome that I'm so excited about. That gives us ability to target whatever disease that basically you want. This is a real example of our manufacturer processes. Basically, what we do to do all this manufacturing of these vesicles as a real world evidence. This is our release criteria. This is what we really put a lot of effort to understand. That is really world-class, fully characterized product. And I'm going to show you some of the data. Basically, we did look at the cells pre-harvest, post-harvest, to make sure before and after harvest, the stem cells that we harvest our exosome, they don't change their phenotype. The phenotype didn't change. We did look at all these cell surface markers. We did look at the CD markers with flow cytometry from different donors, as you can, and they are all MHC2 negative, which is good. It's less prone to induce rejection mechanisms. These are very standard multiple markers of these exosomal based therapeutics, and these are different cell lines that we use. As you can see, look, this one didn't have CD90, so that's why I'm telling you we have patient-to-patient variation. So let's say if you really want to push it forward, we're not going to be using this. So these analytical approaches really help us to narrow down what kind of donor we're going to be using. We use the world-class as of now, NanoView is one of these the best technology in the field to really count the number of exosome and also confirm their surface markers. We use the NanoView. We counted our EVs. This is the total batch. Basically, the number we get, each number can be good for one run of clinical trial, if you want to go low dose. So we look at the size distribution. These are the size or below 50 nanometer. Again, that gives you the ability to develop your release criteria. And these are some of these called like a galaxy. Can we turn off this light? Is it possible? If not, that's okay. So basically, here you're looking at a galaxy. So these are all NanoView images that it captures exosome, and it shows you different markers of exosome, and it's really cutting edge. You can see your vesicles and with those markers. We have never had this ability before. With this technology, you can see your vesicles and you can see do they have CD63, CD81, CD9, all those exosomal markers in real time. And these are from different donors. So it gives you all these, and you see how this donor is less, has less compared to this. All is analytical. That helps us, to see if they are functioning well in the potency assay or not. So these are some of these characterization that we did. Not to mention, one of the questions that I get asked a lot, how stable they are. We did a stability assay. We look at these exosomes sitting at room temperature, 4 degrees, -20, -80. And we look at all these surface markers of CD63, CD81, and CD9, which is established markers. What we found was that actually up to 8 weeks, there were no difference in the samples, meaning that at least in terms of degradation, because when they degrade, you cannot detect them with flow cytometry. And these markers, you see, all very similar. This is the negative control. If they shift to the right, it's positive. You see, all is positive. Room temperature, 4 degree, -20, -80, almost no difference. Same goes here, same goes here. So no difference. Basically, this data shows that there's no difference in surface marker characterization of these exosomes when they are stored at different temperature for 2 months, which is really good. So people think that, you know, if you thaw them for 5 minutes at room temperature, they're gonna be all gone. So this is the real proof. So, and basically, this is what we have done so far. We are looking into put it into rabbit eye, you know, to look at the toxicology studies and the efficacy. So hopefully next year we're going to show you some of those data. So in conclusion, we basically show that extracellular vesicles are considered as a way of cell communication. This is how cells talk. Stem cell EVs have therapeutic effect. That I show you some of these multiple sclerosis animal model. We discussed manufacturing details that significantly alter the characteristics of EVs, and it has to be taken into consideration to have a you know, robust final formulation and product. And also, EVs can be developed in different forms of drug modality. With that, I would like to stop and would be happy to take any question. Dr. Isham?
Thank you very much for the very nice presentation.
Thank you.
I wanted to ask you, for the cargo that's basically included in the EV, this differ from based on the type of the cells that are the extracellular vesicles are derived from, correct?
Yes. So very good question. Parental cell determines some of their characteristics they pass on to their exosome, for sure. But the exosome coming from their parental cell, they're not going to be similar. So we did proteomics assay and RNA sequencing. We compared the cell, the mother cell, parental cell, with their exosome. We saw that, let's say, if you look at like 500 proteins, 100 are only found and enriched in exosome, 100 only enriched in the parental cells, and they have, let's say, 300 common proteins. So still, you look at it as a, a Venn diagram. They share some common, but they have their own specifics as well.
So do you think for application that the exosome that derives from specific type of cells will be tied to the indication, or you think it would be one source derived from from the same stem cells?
So we don't know. That depends on what is your target, function. That's why potency assay comes to play. Let's say you want to target cardiovascular disease. Even if cardiovascular disease, you want to go after inflammation, or you want to go after cardioprotective molecules. If you want to go after inflammation, we know mesenchymal stem cell exosome does a very good job in suppressing immune system. But if you want to go after helping cardiac cells, you need to have, let's say, cardiosphere cells. These are coming from heart. These are heart stem cells. They produce exosome. So then you know that cardiosphere cells for that particular application might be better. So basically, and that needs to be confirmed with the potency assay that you develop. So this is how we define which cells, which target, not to mention comprehensive, as you saw it with multiple sclerosis data, comprehensive analysis on the protein and RNA side has to be performed to show that, okay, if you want to get after inflammation or cardioprotective capacity, you should have those factors inside exosome. Make sense?
Great, yeah, absolutely. Thank you.
Yes, sir. I'm all ears.
So one of your studies that you had there was spinal injury, and my question is, could these exosomes pass the blood-brain barrier?
Beautiful question. I can talk about this for 2 hours, but I keep it short. We did the experiment in healthy animal model and in healthy individual, no, as of today. If there is no implication, like a complication, let's say in the brain, if there is no Alzheimer, if there is no inflammation, if there is no activity going on, blood-brain barrier is intact and this exosome cannot bypass. Unlike some people, they claim, we did not see that. But if you induce stroke and you inject exosome, yes, they bypass, because in the stroke condition, blood-brain barrier is disrupted. I had the data I showed last year, if you recall. So we didn't see exosome passing blood-spinal cord barrier going to the spinal cord of the mouse in the wild type because they were healthy. But in the disease, we saw they bypass and go to the spinal cord. So if there is an inactivity, this blood-spinal cord or barrier or blood-brain barrier are disrupted, yes, they can pass. If it's intact in healthy individual, it's a no. Make sense?
Yes. How about MS? Have you done studies on MS?
Yes, MS was all the animal data that I showed. Yes, in MS scenario, yes. Because you have this gadolinium plaque in the brain or in the spinal cord, yes, there's a lot of activity. Blood-brain barrier is disrupted. Yes, for MS, they can pass to the brain and pass to the spinal cord. Dr. Miyashim, yes.
Thank you for excellent lecture. Thank you. I wanted to ask, for clinical purposes, do you have subclasses of exosome? Like, do you have subclasses for neurodegenerative disorder or cardiopulmonary?
Beautiful question. So my previous mentor, John Lotwell, he published a paper. They asked the question, how many of these exosomes? Did you see in one of the slides, as you can see, let me show you this. You see, some of them have 3 colors, some of them have 2 colors, some of them have 1 color, some of them they don't even show up. So there is a heterogeneous population in this exosome. So the question is, which one is really working, which is not? It's really the current challenge in the field that people are looking into subcategorizing these EVs and way to isolate or sub-purify this subpopulation. So Bjorn Lotwell did a comprehensive study. He found that we have 80 different vesicles. So this is not really pure one type of vesicle. So we have really a huge different population of these exosomes that we call it EV to simplify. So which one really did work in my mouse model? I call it God knows. Sometimes we make joke that with Habib we say that, okay, maybe God even doesn't know, or we don't know. So basically, no one knows. It remains to be seen. But the key is that we don't want to even overcomplicate it, right? If you see efficacy, if you see potency, consistency, it should be good enough to push it forward to the clinic. Even the CAR-T that the Dr. Hisham presented, they are not all the same. You still have some of the not contamination. Some of these cells, they don't really have that CAR construct. Correct me if I'm wrong. So some of them that you get it, not all of them have CAR construct. So some of them even they don't have CAR construct. So these cell-based therapeutics or exosome-based therapeutics, this is their complexity, but this complexity gives you the ability to do something that the small molecules have not been able to do. Make sense? Any other question? Yes.
In your study about the mouses and the exosomes, where did you inject the? How was the administration? It was IV
injection. 1 billion particle in 150 microliter of PBS solution.
Okay, so it was IV.
Which is IV, yes.
Okay, and I'm talking about the exosomes. I mean, the exosome vial. Once we have it in the refrigerator. You said that it's safe to have it for 8 weeks.
Correct.
Okay.
Based off the surface characterization. There might be some microRNAs that are degraded, but they have hundreds of microRNAs. No one can look into 100 microRNAs, see which one is really affected. So, but the idea is that if they keep their integrity, if we can detect them, and the surface molecules are not affected, we consider them as healthy and not affected. Make sense?
Hi. I think we spoke in Orlando about this back in February or March. I'm a big fan of exosomes. I use them all the time, IV, IM. But do we have a problem with the FDA next month?
I'm not a regulatory, specialist.
Yeah.
What I know, if you stick to the principles of science, CGMP, potency, what all the stuff that we discussed, FDA even gonna love you. So I don't see any problem with FDA. They could be your best friend, basically, your best buddy.
Okay.
Makes sense? So yeah, this is very simple. If you stick with the principles, do it the right way, and you're doing it the right way, they have no problem.
Except the FDA said in November of this year they were going to make a ruling on exosomes.
So, again, I'm not expert, but we are doing it right, and we will welcome any FDA to come and see our processes. And we submitted this to a pre-IND application, and we feel so proud to do it the right way, to the best of our ability and knowledge. Actually, let me add this. When we submit it, 3 days after they send us an email, set up a meeting for us, they put 18 people to discuss the project. So they got excited. So we take it as a positive.
Thank you, Dr. Milad. Last question, I hope. Just a quick question about the respiratory and lung diseases as far as the inhalement of the exosomes. Is there any difference between the dermal exosomes versus the MSC exosomes or other exosomes that could be effective on lung and respiratory diseases?
To be honest, I don't know, because I've never done a side-by-side comparison of the proteomics and RNA and the comparing dermal exosome with MSC exosome. There definitely, I can tell you there are going to be some differences and similarities for sure. Which one works best on the, let's say, inflammatory disease of the lung or lung diseases needs to be tested. No one knows. Any other question? So when we do the manufacturing, we get like to the 10 to the power of 12. But we dilute it to the best. So once we get after it comes out of the manufacturing, it's highly concentrated. It's to the range of 10 to the power of 12. So then we can dilute it, let's say 1 billion per cc, 10 billion per cc, 5 billion per cc. And there are these notions in the field that they think 1 billion versus 5 billion versus X billion is better or worse. This is absolute nonsense in the field. And I gave multiple talks on this and try to clarify it. Let's discuss it, because I can talk about it for 3 hours. Let's discuss it after lunch. Any other question? Thank you.